Sporothrix schenckii. Sporothrix schenckii is a dimorphic fungus, meaning it can exist in two different forms, a mold form in the environment and a yeast form in human tissue. This fungus is the causative agent of sporotrichosis, a subacute or chronic infection that typically affects the skin, but can also spread to lymph nodes, bones, joints, and, less commonly, the lungs or other organs. Clinical manifestations of sporotrichosis. Sporotrichosis can present in various forms depending on the route of infection, the immune status of the host, and the specific strain of the fungus. The primary clinical manifestations are cutaneous sporotrichosis, the most common form, often referred to as rose gardener's disease, due to its association with gardening and handling plants or soil. Fixed cutaneous form appears as a painless, nodular lesion at the site of inoculation, usually on the hand or arm. The nodule may ulcerate and become crusty or necrotic over time. Lymphocutaneous form. The fungus spreads along the lymphatic channels, forming a chain of nodules that may ulcerate. This form is characterized by multiple subcutaneous nodules that develop sequentially along the lymphatic drainage path from the initial site of infection. Pulmonary sporotrichosis, a rare form that occurs when the fungus is inhaled. It may present with chronic cough, chest pain, and weight loss. This form can resemble tuberculosis or other chronic pulmonary conditions and typically occurs in individuals with underlying lung disease or weakened immune systems. Disseminated sporotrichosis occurs when the infection spreads beyond the primary site to other parts of the body, such as bones, joints, or the central nervous system, CNS. It is more common in immunocompromised individuals, particularly those with HIV/AIDS or on immunosuppressive therapies. Symptoms can vary widely depending on the organs involved, but may include fever, weight loss, arthritis-like symptoms, or neurological symptoms if the CNS is affected. Osteoarticular sporotrichosis affects bones and joints, often leading to symptoms like joint pain, swelling, and limited range of motion. It is a chronic form that can resemble rheumatoid arthritis or osteomyelitis. Diagnosis of sporotrichosis. Diagnosing sporotrichosis requires a combination of clinical assessment, microbiological tests, and histopathological examination. Clinical examination. A detailed history, including occupational or recreational exposure to soil, plants, or organic matter, can provide important clues. Physical examination focuses on identifying the characteristic nodular lesions along the lymphatic drainage path. Laboratory tests. Culture. The gold standard for diagnosis. Samples from skin lesions, pus, sputum, or tissue biopsies are cultured on Saburod dextrose agar or other fungal media. S. schenckii grows as a mold at 25 to 30 degrees Celsius, forming moist, wrinkled colonies with a brownish or black pigmentation. Microscopy. Direct examination of tissue samples or pus under a microscope using potassium hydroxide, KOH. Preparation may reveal cigar-shaped or cigar-bodies yeast cells of S. schenckii. Histopathology. Biopsy specimens stained with periodic acid Schiff, PS, or Gamori methenamine silver, GMS, stains can show the presence of the yeast form in tissues, granulomatous inflammation, and the presence of asteroid bodies, yeasts surrounded by radiating eosinophilic material. Molecular techniques, polymerase, chain reaction, PCR, highly sensitive and specific. PCR can detect fungal DNA in clinical specimens, confirming the presence of S. schenckii even when cultures are negative or inconclusive. Serological tests, not commonly used due to variable sensitivity and specificity, but may be helpful in some cases. Treatment of sporotrichosis. The treatment of sporotrichosis varies depending on the form and severity of the disease, as well as the patient's immune status. Cutaneous, fixed, or lymphocutaneous. Sporotrichosis.